Hello, everyone, and welcome to the All Things Celiac webinar series brought to you by the National Celiac Association and the Harvard Medical School Celiac Education and Research Program. Today's topic is modern day celiac disease diagnostics, what to know. My name is Chris Rich, and I am the CEO and Executive Director of the National Celiac Association. We at NCA provide educational resources to our celiac community, such as this All Things Celiac webinar series, and we value the opportunity to continue this work in collaboration with the Harvard Medical School Celiac Education and Research Program. In addition to our educational programs, the National Celiac Association offers an extensive support network that reaches from coast to coast and assists everyone from kids and their families with our Raising Our Celiac Kids or ROC program to our focus on older generations with our Support Our Celiac Seniors initiative. You can find more information about the ways that we act as the voice of the community by visiting our website at nationalceliac.org. The highly collaborative Harvard Medical School Celiac Education and Research Program was founded in 2013 and has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and the general public. Education is at the heart of the HMS Celiac Education and Research Program, and these webinars continue to feature multidisciplinary speakers with specialized knowledge on celiac disease, related autoimmune conditions, and nutrition. Today's session is being recorded and will be available for viewing on the National Celiac Association website at nationalceliac.org. You can select the resource tab from the drop-down header on that page and click on NCA webinars. From there, you'll see a green tab that'll link you to the entire All Things Celiac webinar series. The recording of today's session will appear there in approximately 5 to 7 business days. Our moderator for today is Dr. Katherine Olshan. Dr. Olshan is a pediatric gastroenterologist at Mass General for Children. She serves as an assistant physician at Massachusetts General Hospital and as an instructor at Harvard Medical School. She is a member of the Center for Celiac Research and Treatment at Mass General for Children and involved as a sub-investigator in multiple clinical trials currently enrolling participants with celiac disease. In addition to her medical degree from the Medical College of Wisconsin, Dr. Olshan completed her residency in pediatric medicine at the University of Massachusetts Medical School, UMass Memorial Medical Center. She also completed her fellowship in pediatric gastroenterology at Mass General for Children. We are honored to have her with us here today. So Dr. Olshan, welcome.
Thank you so much, Chris, and thank you to the NCA for having me today for this very interesting webinar about modern-day celiac disease diagnostics and what to know. Available during this webinar will be a Q&A feature where you should feel free to submit general GI and celiac questions related to the topics we will be discussing today. We ask that you not put any personal medical information there. CEUs are available for registered dietitians, nurses, physicians, and social workers. There is a new system for claiming CEUs. Please watch the chat for that information. I'd like to introduce our first speaker now. Dr. Javier Villafuerte Galvez is a gastroenterologist at Beth Israel Deaconess Medical Center and a faculty member at Harvard Medical School. His practice primarily focuses on patients with celiac disease and other immune-mediated digestive disorders. Additionally, he serves in a community-based practice in the Chelsea, Massachusetts area. His research on celiac disease has explored factors that affect adherence to the gluten-free diet, quality of life, and how ethno-racial factors influence the diagnosis of celiac disease. Dr. Villafuerte is passionate about patient education, participating in educational seminars, and creating materials in both English and Spanish to serve diverse patient communities. If you'd like to go and share your slides now, thank you.
Thank you so much. Let me just quickly share the slides. Thank you so much for the introduction. I'm really honored to be here to talk about a subject which is like my day-to-day practice, a diagnosis of celiac disease. So I'll be talking about what we were doing in 2025. It has not changed dramatically from the time I trained. So I have no relevant disclosures to this talk, and the objectives are to first present some real-world scenarios in celiac disease diagnosis, Names are changed, and also the histories just a little for privacy. Review the consensus guidance in celiac disease diagnosis, and assuming we have enough time, highlighting the limitations of our current approach. So I'll start with the first case. This is Tyler. He's a father from Wellesley. He's 42 years old. He's completely healthy. He feels great, but he has a 5-year-old son who, over the past year, had a stunted growth curve and slightly irregular bowels. And after about a year of medical appointments, was diagnosed with celiac disease. He's told that family members at a higher risk. His PCP gets a blood test, the tissue transglutaminase IgA or TTG-IgA, which results at 77 with an upper limit of normal at 20. And I will be referring to the test results often as multiples of the upper limit of normal. So for instance, 77 with an upper limit of normal of 20 would be a 3.9 times the upper limit of normal. Anyway, he's recommended by his PCP straight to go to a gluten-free diet, but his trusted pediatric gastroenterologist recommends biopsy confirmation before starting a gluten-free diet, and that's how he ends up at the Celiac Center at BI. Before the resolution, I'll go to a second case. This is Lynette. She's 34. She's Dominican, and she's a nurse associate. She is 22 weeks pregnant when this first happens. She's had years of mild GI symptoms that were labeled as mild irritable bowel syndrome. She has a history of long-standing anemia, for which she received supplementation quite a few times, and also during the prenatal period. Her hemoglobin is at 8.2. She does not have heavy menstruations. She's iron deficient with an iron to TIBC ratio of 3%, so quite iron deplete. And her OB gets quite a few labs, but among them tissue transglutaminase IgA that comes back at 1.3 times the upper limit of normal. And she's recommended to start on the gluten-free diet. She undergoes an iron infusion. She feels so much better. The anemia resolves. And after the birth of her child, her tissue transglutaminase IgA has normalized 12. However, a little more than a year later, her gluten-free diet has been taxing. It has been expensive. Her family does not buy in. Mother-in-law says celiac disease does not happen in Latinos, and gluten-free is a fad. She's also getting constipated and bloated since she's doing the diet. So her gastroenterologist proposes a 2-month gluten challenge, and by doing that, she asked, like, what's a gluten challenge? And she says, just eat normal. At the end of these 2 months, her TTG-IgA is more than 150, so more than 10 times the upper limit of normal at that lab. She gets an upper endoscopy, and the duodenal biopsies are normal. And then everyone's confused, and she's referred to the Celiac Center. So just so far to kind of summarize, first of all, blood tests, as you can see, seem to vary in units and reporting quite a bit. And these are cases from the Boston area. This is not even like at the national level. You also will see that some physicians recommend gluten-free diets without endoscopy or small bowel biopsies. Celiac disease can present at any age, have mild or no symptoms, and present in any gender or ethnicity. It does happen in Latinos too. Anemia in a woman of childbearing age is often brushed off, to maybe heavy menstruations that are not confirmed, but this is a very common scenario of diagnosis of celiac disease. And avoiding gluten is not easy for everyone. It can be expensive, and also it counts when your community is aware of a gluten-free diet being a treatment for a disease and not a fad. Back to Tyler. So Tyler is still eating gluten. I see him in the office. I schedule him for an upper endoscopy, and his small bowel, his duodenum shows this nodularity, which is like a fancy term for bumpiness, and also the folds of his duodenum have this. These little creases that we call scalloping. We cannot see villi on endoscopy easily. And the biopsies show shortened villi with increased intraepithelial lymphocytes, which are white blood cells, and we make a positive confirmed diagnosis of celiac disease. So good for Tyler. Going back to Lynette, her numbers are puzzling. So within 4 weeks of a gluten challenge, her serologies went up to 10 times the upper limit of normal, which I honestly do not usually see. And if you look at on the left, this is a graph from Dan Leffler's study of gluten challenges. And you can see that after a 2-week gluten challenge, it seems that at day 28, the TTG goes up to 2 times the upper limit of normal. So this is weird to begin with. And that at the time I see her TTG has gone to 11. So it has completely normalized. This is very suspicious. It's supposed to halve every 3 months on the strictest gluten-free diet. She gets some genetic testing, the HLA-DQ, and she has half of the DQ 2.5 variants, so the A105, and also has the DQ8. So while we wait, we have her pathology blocks reviewed, and we get additional cuts, and ultimately she does have patchy shortening of her villi and a marked increase in her intraepithelial lymphocytes, and a positive diagnosis is made. But just as to highlight that it, not even if it's in the biopsy, it may be missed. Not everyone is experienced at reading these types of biopsies. All right, so now the clinical iceberg of celiac disease. Most people with celiac disease are asymptomatic and are found by screening or by chance, like Tyler. Some people have atypical symptoms, but those are above water, like anemia, osteoporosis, elevated liver tests, and think of Lynette here, who had anemia. And then the tip of the iceberg is the patients who have the classical picture, diarrhea, weight loss, and malabsorption. Now, these are not the only symptoms. There is a laundry list, and this is from the ACG guideline. And these are conditions, these are symptoms and conditions where celiac disease is more common than in the general population. So malabsorption, diarrhea with weight loss, and a myriad of them. There's also conditions where celiac disease is not more frequent than the general population, but their association with celiac disease makes them relevant to test because of potentially reversibility of the treatment. And among those, you have infertility, malabsorption of thyroid hormones, ataxia. We recently reported a case of that, chronic joint pains. So this is when to test, and you can see the reasons to test are quite a few. How to test? So our main blood test is the tissue transglutaminase immunoglobulin A autoantibody, or TTG-IgA. We also test for total IgA because 2 to 5% of people with celiac disease are deficient in IgA and then may have like a false negative TTG-IgA. And I wanted to explain how good is a test. So sensitivity means that the test will be positive when patients have celiac disease. And in the case of TTG-IgA, it's in 90 to 99% of patients that it will be positive. Specificity is that it will be negative in patients without celiac disease. And for TTG-IgA, it's 91 to 98%. But, be aware that this is not the same that if positive, you will have celiac disease, or if negative, you don't have it. those are the positive and negative predictive values, and those are different. Those depend on the prevalence of the disease in the population at hand. So that's a very important nuance about how good a test is. A test is good for a specific population with specific characteristics. It's not good on its own. The second way we test is with a confirmatory biopsy of the duodenum. We usually biopsy twice in the duodenal bulb, the first part, and 4 times in the distal duodenum, the second, third, and fourth part of the duodenum. And we must see decreased shortened villi and increased intraepithelial lymphocytes at a rate of at least one of them every 4 intestinal cells. Diagnosis without biopsy. This is a little newer, and we have the European pediatric guidelines. I'm not a pediatrician, but I read the guidelines, and you will have pediatricians to discuss this further, and also the ACG guidelines. So this is a bit newer, and a diagnosis without biopsy, first of all, can only be done when the patient is eating gluten. It can be done in adults if they're unable or unwilling to undergo an upper endoscopy, and in children if they have characteristic symptoms, which, as you can see, is a very vague thing, and if there is family agreement. And the requirements are that the patient must have a tissue transglutaminase IgA of more than 10 times the upper limit of normal, and an endomysial antibody that is positive in a different sample. They are moving towards this being another TTG-IgA in a different sample, also in other guidelines. But what is unable and unwilling? Unable, I go to Lynette's case, who had a positive serology when she was pregnant. That's where really, the risk of an upper endoscopy is probably higher than the potential benefit. And unwilling is, when there is a major fear or any other type of barrier. How to test when the patient is not eating gluten? First of all, the idea is hopefully that this doesn't happen, but the algorithm that our societies use is to do genetic testing for the HLA-DQ type and look for what we call a permissive genetic variant. So what is the HLA-DQ? The HLA-DQ is a marker in cells called antigen-presenting cells that binds to gluten and presents this to T cells that are immune cells that will recognize the combination of gluten and this HLA presenting molecule. And Dr. Tye-Din will go further in details about this. So if you have a permissive genetic variant, you can proceed to a gluten challenge. What is a permissive genetic variant is something that's still debated. The most common is a DQ 2.5 variant, and if you have 2 of them, your probability is around 15%. If you have a combo of 2.5 and 2.2, it's a little less, and then if you have a combo of 2.5 and 8, even a little less, and then a combination of 2.5 and any other, then you have the 2.2, and also the half DQ 2.5, which is what Lynette had, which is only the DQ A105. And then any DQ type where, as far as we know, there is no celiac disease. However, there are some data out in Italy, Spain, and some data from BIDMC from our colleague Emily Therian that there may be some HLA-DQ7 people. And labs have different thresholds. Until last year, the BIDMC lab would not report DQ 2.2 as a permissive variant, for instance. And also physicians have different thresholds of when they would do a gluten challenge. And I would do a gluten challenge even with a half DQ 2.5, because we do have patients who have real celiac disease with half DQ 2.5. All right, so we found what the permissive genetics are, and then you gluten challenge people. Dan Leffler showed that 14 days in a perfect research environment may be enough to see changes. I don't think this is easily reflected in reality. Before telling you a little more about what happens in a gluten challenge, I want to show you how the villi look. This is a normal villus that has a height and has crypts, which are the areas where the cells that are the stem cells of this intestine are, and that has a normal depth. In celiac disease, the villus is short and the crypt is longer or deeper. So the ratio of the villus height to the crypt depth decreases dramatically in celiac disease. So across the gluten challenge, by day 28, with a 14-day gluten challenge, you can see that the villus height to crypt depth ratio decreases from around 2 to a little above 1 on average. Now, this is something that's detected in a research setting, so don't go looking for villus height to crypt depth ratios on your standard pathology reports, but it is a proof of the concept. And you can also see a rise in the tissue transglutaminase IgA by a factor of 4. So this is how the gluten challenge works. It gives us serology and it gives us a consistent biopsy. Practicalities of the gluten challenge, it is very normal to have some fear around it. Many of my patients will just not get it because they're afraid they will feel terrible. Dan Leffler's study proves that 3 to 6 grams of gluten may be enough to trigger a response, though it may be enough in a perfect research setting. 14 days could also be enough, but in the real world, no pathologist is really measuring the villus height to crypt depth ratio. I have to chase pathologists to try to get anything close to that. And even with longer challenges, positive biopsies can be missed by competent pathologists. Remember Lynette's case. It's also hard to time the upper endoscopy with a challenge. And if the patient's told to eat anything, you don't really know if they're getting 3, 6, 12, or 0.5 grams of gluten per day. Gluten-containing foods also have other components, including FODMAPs, that can cause symptoms that are unrelated to gluten. So my current approach, and this is not advice, this is how I've been working little by little, is first I book my upper endoscopy and I ask patients to start 6 weeks before the upper endoscopy on the weekend. This approach with using the Vital wheat gluten flour I took from our colleagues in Australia, Dr. Bob Anderson, and I use 1 tablespoon on an empty stomach. I have patients either blend it or shake it with any liquid. If the patient has mild or moderate nausea on days 1 to 3, I continue at 1 tablespoon, which is about 10 grams. It usually, most patients, even those who truly have celiac disease, actually stop having that nausea by day 3 or 4, at least in my experience. I don't think there's a lot of data on that. And if there's no nausea, actually go to 2 tablespoons to try to make it more sensitive. Though there's no great data for that. And I get a TTG-IgA and DGP-IgG at 6 to 8 weeks. I have the patient have strict check-ins via the patient portal to tell me how they're feeling. Most of the time they tolerate this quite well. But our approach isn't perfect. Our serology test has variability in accuracy. You have false positives, you have false negatives. There's also seronegative disease. We have a few patients with that. And hospital systems may change their assays without validation. The IDMC changed its assay 3 years ago without really asking anyone. And the diagnostic performance of other tests besides the TTG-IgA is less known outside of rare circumstances like IgA deficiency or gluten challenges. Biopsies, there isn't frequent adherence to biopsy protocols. Many people will not biopsy the bulb and the distal duodenum in separate jars or at the ideal place. The disease can be patchy, so you may end up biopsying what's normal and not what's abnormal. In rare cases, the disease may be limited to the jejunum, although that's quite rare. And then false negatives and false positives can depend on the pathologist's experience and familiarity with celiac disease. We do have a few false positives per year that come to the IDMC. All right, so this is the non-biopsy diagnosis approach in adults. This is a paper by a broad group across the UK and the US, where they did a meta-analysis. So they analyzed multiple studies, 18 studies total, and they pulled it together through statistical techniques with over 12,000 participants in 15 countries. And they found that the test was, very specific. TTG IgA of more than 10 times the upper limit of normal is very specific, and had an overall positive predictive value, meaning that if it's positive, you have the disease 98% of the time. Now, the issue is that only one of 18 studies had US data. One was from Northern India and one from Turkey. Otherwise, they were from Europe and Oceania. And more than and around 50% of studies did not have TTG-IgA assays that were used or available in the US. Also, there was no analysis by TTG-IgA assay, because that makes a difference. If you just average everything, well, you'll average things that are not necessarily similar. So with this study, I'm concerned about the generalizability to a population with high ethno-racial variability, which may be reflected in its composition in DQ 2.5, DQ 2.2, and DQ 8 variants. With different dietary habits, maybe different gluten ingestion. The other concern that's actually brought up by the authors of the paper are that non-biopsy is very different from non-referral. And this is something we're seeing more and more, that people get a positive test. Their primary doctor just tells them to not eat gluten, and then they never see a gastroenterologist or even less a celiac disease specialist. And then the other thing is the true adherence to the more than 10 times the upper limit of normal in the real world. As you saw with Tyler's case, his elevation was not more than 10 times the upper limit of normal, and he was told by his primary care doctor to just avoid gluten. So in that case, the chances are not as high that he had celiac disease, although he did. And this is in children. This is a study actually by many people who are here did it in children, done by Dennis Chang and Jocelyn Silvester. And this is very nice because this was done in North America, so we know that it can be applied to our population. And the study is actually a multi-center study of pediatric centers, so it's not a meta-analysis where they take other studies and try to pool them. So this is like a common design. So the quality of the data is definitely more in my mind. And only less than 50% of patients with TTG-IgA will have more than with a positive TTG-IgA will have more than 10 times the upper limit of normal. So a non-biopsy diagnosis cannot be applied to more than half of patients. The other thing is like 15 to 20% of patients with a TTG-IgA, according to the study, will not have definitive celiac disease. And around 5% with a TTG-IgA more than 10 times the upper limit of normal will not have definitive celiac disease. They also found that the cutoff of more than 10 times the upper limit of normal is most inaccurate in patients with type 1 diabetes. And they also found something more concerning there, and this is in assays, TTG-IgA assays available in North America, that there is an 8 to 17% discrepancy between assays. As you can see in this graph, towards the left, you see the lower multiples of the upper limit of normal, and around 10, it reaches a plateau, but there's still about 5% of people that with a high TTG that will not have celiac disease. And should they be gluten-free? Well, that is a question that we don't know, because they may be symptomatic or not. But they may just have transient elevations, which may not be meaningful. All right. So now
Doctor, a couple of minutes left.
All right, that's perfect. So for my take-home points, celiac disease is a great masquerader. It can present in many, many ways. It can go from no symptoms to just having some laboratory or imaging clues. to multi-system severe manifestations. Active gluten intake allows definitive diagnosis with serology and duodenal biopsies. Gluten-free patients with permissive HLA-DQ gene types can go to a gluten challenge and then the standard testing. But both serology and duodenal biopsies are imperfect tests. Should we skip the biopsy only when the burden of the upper endoscopy demonstrably outweighs the diagnostic uncertainty? And that's a really personalized decision that should be made with a celiac disease expert. And non-biopsy practitioners should deeply understand the data on diagnosis and the burdens of the diet before sending someone with a low positive on a lifelong gluten-free diet. I think these are all the points that I wanted to make, and I am very happy to discuss any questions. And thank you so much for being here and for all your time.
Thank you so much for that wonderful talk. I'd like to take this opportunity to introduce our next speaker, Dr. Jason Tye-Din, who is the director of the Snow Center for Immune Health at the Walter and Eliza Hall Institute in Australia. A practicing gastroenterologist and immunologist, Dr. Tye-Din is globally recognized for his pioneering research focused on understanding gluten immunity. His discoveries are informing the development of improved diagnostic tests and treatments for people with celiac disease. He directs a celiac clinic and clinical trial site at the Royal Melbourne Hospital and works closely with academic and industry partners. Go ahead and start his pre-recorded presentation, given the time zone.
So hi everyone, it's a real pleasure to be able to talk to you today, and I'm sorry that I can't do it live. I'm very grateful for Dr. Silvester, who's standing in for me at the end of my presentation and should be more than capable of answering all your questions. I'm very grateful to the NCA for the invitation to speak as well. So I'll be touching on modern day celiac diagnostics, and in particular focusing in on a blood-based test that's been under development by my group and other collaborators recently. So disclosures, these are my disclosures. I consult for a range of industry groups developing new therapeutics for celiac disease. I won't be talking about those today. So you would have heard from Dr. Javier about the current diagnostic approaches for celiac disease. And essentially we have two major tools, the serum autoantibody test or celiac serology, the main one being the transglutaminase antibody test. And then with a positive result, we typically confirm the diagnosis by undertaking biopsies of the small intestine to show the typical damage of celiac disease. And as many of you will know, in select cases in children, when the transglutaminase level is very high and certain other criteria are met, the diagnosis of celiac disease can be made without the need for a small bowel biopsy. But this approach is not perfect. There are a number of potential limitations, and I'm sure you've heard about this in detail from Dr. Javier. The upshot, though, is that of the 1 to 2% of people around the globe with celiac disease, many people remain undiagnosed. And this is a problem because we know that undiagnosed disease is associated with adverse health effects in the long run. So there's a real need to improve the way we diagnose celiac disease to make it more accurate and also more simpler, and ideally something that can work even when people have reduced or removed gluten from their diet. So one way we could potentially do this is by looking for the cells that cause celiac disease. These are the so-called gluten-specific T cells. But up until recently, there really wasn't a practical way to do this. So let's take a little bit of a deep dive into celiac disease immunology. So on the figure that you see in front of you, really it shows what happens when someone with celiac disease consumes gluten. You can see the gluten fragments passing in at the top of the screen across the lining of the gut. And then these are modified by the enzyme transglutaminase. And these modified gluten fragments bind very well to T cells, which then trigger an immune inflammatory reaction. Now, those T cells are used by our bodies to fight off infection or ward against cancers, but they, in people with celiac disease, for some reason also see gluten as an invader and react adversely to it. So the presence of gluten-specific T cells is something that we see in people with celiac disease, but in people without celiac disease, those gluten-specific T cells are not really present, and we can't detect them in the bloodstream or in the bowel. So the key here is to say that the gluten-specific T cell is essential for the development of celiac disease. And so if we can actually measure those cells either in the bowel or the bloodstream, we could have a very effective diagnostic test. So why can't we do that? Well, the big problem is that detecting these cells in the bloodstream is very difficult because they're very rare. There might be only a handful of these cells circulating around in a vial of blood. So we can't just simply take a person's blood and then just hope to see these cells circulating in it. And we can detect the cells in blood if we use very sophisticated techniques, things such as tetramers, but these require large volumes of blood, can be quite sophisticated and technically involved, and you need to know the HLA of the person undergoing the test. So there are limitations to this, which mean that it's not a practical test that will ever become something that we would do through a standard pathology lab. So is there a better way? And I'm going to show you over the next few slides that we believe there is. And these findings came about from a clinical study of a drug that was being tested in celiac disease. And even though that was not successful, the trial showed that when people were being injected with these gluten peptides in their bloodstream, they would be producing chemicals such as one called interleukin 2 that would increase to a large level that was detectable in the blood. And this occurred in people after injections of gluten, but not after injections of placebo. So we went on then to test people with celiac disease to see what would happen if they consumed gluten. So if you consumed a bit of gluten in a drink, what would happen? And lo and behold, within a few hours of drinking some gluten, this same interleukin 2 signal appeared in the bloodstream within a few hours and increased and peaked after 4 to 6 hours and then dropped away and reduced. And this was seen in people with celiac disease, but not in people without celiac disease. This was a really important finding, and what made it possible was using technology that could detect these chemicals at a very low level in the blood. And this particular machine you see on the slide is a mesoscale discovery platform device, and it can detect the equivalent of a single grain of sand in 57 Olympic-sized swimming pools worth of water. So in other words, it can detect very, very low signals, and that's really important because even though the gluten signal in the bloodstream goes up considerably after gluten, the values are still extraordinarily low. So in order to be able to detect these changes, we need this type of equipment. And what we've also shown is that the level of elevation of this interleukin 2 in the bloodstream matches how sick a person is with celiac disease after they eat gluten. So if you're the type of person who vomits after gluten, you're more likely to have a higher interleukin 2 elevation in your bloodstream. And conversely, if you have no symptoms at all after eating gluten, you will still have an interleukin 2 elevation, but it won't be as high. And you can see on this figure that those people with the strongest symptoms had the higher levels of interleukin 2. And we typically saw the vomiting and symptoms like vomiting and nausea occurring around the time that the interleukin 2 level was peaking. Now, Dr. Silvester and other colleagues, such as Dr. Leonard, have done an excellent study to test the interleukin 2 measurement in the bloodstream against some of the more traditional measures that we use, such as the celiac antibody test or the small bowel biopsy and duodenal histology test. And this figure here really summarizes the results. And you can see here that there were 7 people who had 3 grams of gluten a day for 2 weeks, and 7 people with celiac disease who had 10 grams of gluten a day for 2 weeks. And in both cases, 4 hours after a person with celiac disease had their first dose of gluten, you could measure that interleukin-2 signal very consistently. But at the 3-gram dose, even after 2 weeks of gluten, there still wasn't consistent changes in the small intestine, and you needed to increase the dose to 10 grams a day for 2 weeks in order to demonstrate that histologic damage in the bowel. So what does this mean? Well, it means that this interleukin-2 signal is very sensitive and can detect even small levels of gluten exposure in a person with celiac disease. And very quickly, you don't need to give it for 2 weeks. A single dose is enough to lead to that interleukin-2 elevation in a very accurate manner. And so not only does this open up the possibility of a diagnostic test, it also allows us to track the gluten-specific T cell, which could be useful in clinical studies of new drugs. And so this is a figure here on the left showing how this measurement of interleukin-2 in the bloodstream can actually be a useful differentiator between celiac disease and people without celiac disease. So on the left, you can see these blue dots, which are people with celiac disease, and above the dotted line at 2 is a positive result. You can see that most people with celiac disease will have a positive result to a gluten challenge and measurement of interleukin-2, whilst those people without celiac disease do not mount a response. So this equates to a very accurate test. It means it's 97% sensitive. It will detect most people with celiac disease, and it's 100% specific. In other words, it can exclude celiac disease in a negative result with perfect accuracy. So this is a really promising approach to the diagnosis of celiac disease, and we've gone ahead and then tested and compared this test in people with celiac disease to people with self-reported gluten sensitivity. That's the figure on the right there, and also to healthy volunteers. That's the figure on the left. And you can see in healthy volunteers without celiac disease, there's absolutely no signal at all noted. Whereas in celiac disease, you can see that it increases. And again, on the right, in the separate study, we showed that people with gluten sensitivity, that's the far right figure, really was flatlining, except for one individual who had a bit of a spike. And we did worry about that person having celiac disease, but that person was unable to tolerate a 6-week gluten challenge in order to get a biopsy. So unfortunately, we weren't able to confirm celiac, but we do believe that person did. And on the left with the celiac disease, 26 people, you could see that most had a very high elevation of the interleukin-2 after a single dose of gluten consumed, confirming that they do have celiac disease. But interestingly, you can see at the bottom there were 2 people in the purple color that did not mount a response. We thought that was a little bit unusual, so we went and reviewed those people through the clinic. And it turns out after those people were asked to go back onto gluten for a couple of months with repeat biopsies and blood tests, it did not show celiac disease. And these were 2 people who were probably misdiagnosed and never had celiac disease in the first place. And they both, interestingly, never had positive celiac antibodies. They were only diagnosed based on villus atrophy and symptoms of diarrhea. So this was a massive change for them, of course, because we undiagnosed them. So an accurate diagnosis of celiac disease is clearly very important, both in the positive, but also excluding it in people who actually don't have it. So we've gone one step further, because the test that I've talked about to you to date involves a single dose of gluten and then a blood test at baseline and 4 hours later. What we've since done is thought, well, what if we put the gluten in the test tube and mix the person's blood with the gluten in the test tube instead of asking that person to consume gluten? And so that's exactly what we tested. So you can see here a schematic diagram of a person having some blood collected. In that tube there, we put some gluten fragments or gluten peptides. This was then incubated for 24 hours. It was put in an incubator, nice and warm. The cells, if there were gluten-specific T cells present, would then produce the interleukin-2 because they were triggered by the gluten. And this then led to a signal of interleukin-2 that can be measured a day later using the machine. So we got a result within 24 hours. And if there was no interleukin-2 signal, it would imply the absence of gluten-specific T cells and therefore the absence of celiac disease. So this was obviously very appealing. How well does it perform? Well, we showed that it was extremely sensitive. This is a very, very complicated figure here, which essentially tells us how we could detect a signal and how low can we detect a signal. And what we showed here, you can see the little circle, that we were able to detect a single gluten-specific T cell in a single tube of blood. So that's how sensitive it is. In other words, if you have celiac disease and you're likely to have just a few of those T cells circulating in your bloodstream, because they reduce when you're on a gluten-free diet, we need to be able to detect it, and this test is able to do it. And we've done some additional studies to show that the gluten-specific T cell is the cell that's actually producing the interleukin-2. And what's really interesting is that this test is able to predict the likelihood of a person's symptoms to gluten. So we gave people some gluten, and you can see on this figure that the people in blue vomited. The people in green didn't vomit, but some people still had some strong symptoms. But there was a sort of differentiation. When you look at those gluten-specific T cells in the bloodstream using that very sophisticated method, you can then predict the likelihood of vomiting, because the people who vomited had more of those gluten-specific T cells in their bloodstream. And when we did our whole blood test, the test that I've just been talking to you about, and you got the blood from someone with celiac disease and mixed it with gluten, again, you could see that differentiation in most people between those who vomited and those who didn't. This person up here is a little bit of an outlier in the red circle, and that person had severe lethargy. So even though they didn't vomit, they did have severe symptoms, but it was a different symptom. So I think what this is telling us is that by using this immune test on a blood test, we can actually predict the likelihood of the severity of gluten-induced symptoms. And this could be very important in clinical studies, because instead of actually having to feed people gluten, we can potentially rank them by likelihood of symptoms to gluten based on this immune result in the test tube. So how does this test perform when we test lots and lots of people? So here we've gone ahead and tested nearly 200 people with celiac disease in Australia, and these are people on the left here you can see with treated celiac disease on a gluten-free diet. The second column are people with active celiac disease. In other words, they've just been diagnosed, they're still eating gluten, they've just had a gastroscopy to confirm their diagnosis. The third group in green are people who don't have celiac disease. And then the final group in purple are people who don't have celiac disease but report feeling sick with gluten. They're gluten sensitive. And you can see here that anything over the dotted line equals a positive result. And you can see that the people who are celiac, whether it's treated or active, are mostly above the line, and those without celiac are mostly below the line. And the test can be further refined by looking at the cutoffs that we use. So even though this looks like there's some people on either side of the line, we can improve that performance by evaluating different cutoffs. So we can look at the absolute amounts of interleukin-2, and that reduces and removes some people who are on the wrong side of the line. And ultimately that means we can detect at least 90% of people with celiac disease with 95% specificity. Now these numbers are actually very good and are comparable to what we see with the transglutaminase assay in someone eating gluten. But what's striking about this result is that these people here in blue on the left were on a strict gluten-free diet, and they would have otherwise had negative celiac testing. This test was able to detect that they had celiac disease without them needing to eat any gluten whatsoever. Now, one point of note is that the DQ8 people, these are the less common genotype people, probably under 10% of people with celiac disease in most areas, had a sensitivity of 56%. And it means that the DQ8 fragments inside the test tube probably need to be adjusted. But this tells us, though, that for the most common gene type of celiac disease, the test is performing exceptionally well. So what next? Well, we're actually now needing to test more people. And that includes people around the world, and it also includes children. So we have Dr. Silvester, who's involved in this study, and she's been involved in leading a lot of the pediatric validation of this test, and Dr. Tye-Din and other collaborators are also involved, Dr. Stahl and Lou in Denver. So there's several groups who are involved in testing this assay. The hope is that the company leading the development of this assay will take it forward to labs that allow eventually it to be used in the clinic, so that you can see your doctor and get this test done, or family members or friends can do that. And interestingly, this is not just the only use for the assay. It can also be used in celiac drug studies to understand if the drug is actually acting on the relevant gluten-specific T cells, and we're also using it to understand symptoms better. What do I mean by that? Well, just to take a quick detour, as we discussed, when people with celiac disease eat some gluten, they can develop an acute response. So on the far right of the slide, you can see that about 80% of people with celiac disease are symptomatic. Nausea, vomiting, diarrhea, tummy pain, bloating, lethargy, brain fog, headache, those sorts of symptoms. Why are some people symptomatic and some not with gluten? We have no idea why there's so much variability. What we do know, though, is that gluten does trigger these increasing chemicals in the bloodstream, like interleukin 2. And we believe that this is very important in symptoms, because the higher the interleukin 2, the stronger the symptoms. And we believe that there is an interaction with the nervous system of the gut, which releases a range of chemicals like serotonin that can trigger symptoms. So we've got some active research looking at that link between gluten, the immune markers like interleukin 2, and some downstream chemicals like serotonin that can cause symptoms. And the hope is that this will allow us to better understand why symptoms occur and develop better ways to prevent symptoms happening, or even how to abort symptoms occurring in people who have been accidentally glutened. And as I mentioned, there's some broad applications for this approach, measuring these chemicals called cytokines like interleukin 2. It can be used as a diagnostic. The other role that people might wonder about is, could we use it as a way to monitor celiac disease? As you all know, we often will see people again after they've gone gluten-free and ask how they're going. We may perform celiac antibody testing to see if it's coming back down to normal. And in some cases, that people will have another gastroscopy to see if their bowel has healed up. And that, while that is a very good way to assess healing on a gluten-free diet, it is an invasive test and may not be always practical to do on everyone. So can we use this immune assay to monitor disease? Well, we're not quite there yet. Further studies need to be done to best understand whether it has a role for monitoring disease, but there is the potential to do that. It's certainly being used in clinical studies of drug therapies to monitor whether the drug is adequately blocking the gluten-specific T cell, and so it's very useful in that setting. And as I mentioned, it's a way to track symptoms caused by gluten. And more broadly, this approach of measuring in the bloodstream these chemicals like interleukin 2 after gluten is a really interesting way of assessing whether the things that people are consuming are safe or not. And so it's allowing us to establish things like safe thresholds for gluten, or understanding whether certain grain types might trigger abnormal immune responses, such as oats. And this is all the topic of another presentation. So, current worldview, I guess, is that we use antibodies to screen for celiac disease, and then we go ahead and look for evidence of gut damage to confirm the diagnosis. And there's a range of things that we can look at in terms of measuring end organ damage separate to the gut, like bone density. We also look at symptoms as an important readout of the effect of gluten on people. But what we know is that before antibodies and that end organ damage is that there's the T cells and B cells that are important in leading to all of these things happening. So if we can measure the T cell, perhaps we have a much better way of diagnosing disease. And so, as you've heard me talk about, we now have a blood-based test that does measure the T cell and potentially provides us with a way to diagnose celiac disease. Are we there yet? No. I think there needs to be more studies to confirm that it works in children and also in adults around the globe, but it's certainly very promising, and it really is offering a new way to diagnose the disease. And I think once the field get more and more data, and it's really thanks to all of you who participate in these studies that we get this type of information, but once we can confirm that it's working, it's my belief that we may eventually evolve how we define celiac disease. Currently we define it based on the presence of the gut damage, the villus atrophy, and the positive antibody test, but ultimately we may define celiac disease as a gluten-induced immune reaction and something that's caused by T cells. And if that is the case, then we'll be much less reliant on strict definitions around gut damage, and it may mean that we'll actually then start to encompass a broader group of people who could benefit from that diagnosis and treatment with a gluten-free diet. So I'm going to stop there and say thank you very much again for having me. From my point of view, thank you to all the volunteers who take part in our research and our teams who've been involved and our funders. A quick plug that there's the International Celiac Disease Symposium in Melbourne in 2026. There's a website there that you can visit. Please take it as an opportunity to come visit Australia, and thank you again.
All right. Wonderful presentation. I'd like to take a moment just to introduce Dr. Jocelyn Silvester, who will be answering questions during our Q&A on behalf of Dr. Tye-Din. Dr. Silvester is an associate professor of pediatrics at Harvard Medical School, co-director of the celiac disease program at Children's Hospital, and associate staff at Beth Israel Deaconess Medical Center. Her research interests include the diagnosis and management of celiac disease, with a focus on assessment of disease activity and what happens after the diagnosis of celiac disease is made. All right.
Dr. Olshan.
Hi. Okay, so I'm going to pull up some of the questions. I think first a question that had been posed about the diagnosis of celiac disease. And it seemed like there were questions about, is there any way to know how long someone has had celiac disease based off of symptoms or testing or anything like
that? I think the way that we can know is if we have prior testing that was negative. So if somebody has an endoscopy and their intestine looks normal and they're eating a lot of gluten, and then subsequently they have an endoscopy and they have celiac disease, they probably genuinely did not yet have celiac disease when they had the first biopsy. But symptoms are unfortunately nonspecific, and as you saw, serology is not 100% correlating with the intestine, so it's hard to know, and antibodies can go up very quickly.
I agree with that. I guess like when you see complications that take a while, like osteoporosis, you could somewhat infer that it's been going on for a while, but it's not a slam dunk either. And repeated testing is great. Like when we have patients that have had pediatric care, or I have a couple patients that got tested quite a few times and were negative, and then they became positive, but they had family history. That's why they were tested so much. But yeah, it's sadly we cannot quantify. We can maybe have like a rough estimation based on complications, especially in adult patients, with osteoporosis. But that's as far as we can go.
Wonderful, thank you. And then a question about the IL2 testing. Is there any evidence that it's more accurate depending on what genotype you have for celiac disease? And is there any role in testing that in addition?
So the amount of signal you get is related to the number of circulating T cells you have. Dr. Tye-Din showed that data. And so it matters a little bit more how many cells there are that can give that signal than whether they're DQ2 or DQ8. But in general, for anything that we do, we get more signal from DQ2 than we do from DQ8.
Thank you. And then shifting over to diagnosis again, if a patient has been diagnosed with dermatitis herpetiformis, previously with DIF and anti-TTG IgA antibodies, is it still necessary to proceed with a duodenal biopsy to confirm the diagnosis of celiac disease, or do you have enough information for that?
It's probably enough information. I would, as a if I could get a biopsy, just in, the scenario is for me is if this person does not respond to gluten avoidance and has symptoms, will I go and find a positive biopsy again, and will I call them refractory, or so that I guess that's the only difficulty, but it's one form of tissue diagnosis, so it would be acceptable.
Particularly if the patient is going to adopt a strict gluten-free diet. I think if there's some question about whether or not the diet is going to be adopted, then it's really important to get the biopsy.
Yeah. I don't get that one too often. It's usually the other way around.
Perfect. All right, just looking through the Q&A. All right. Any thoughts on whether an individual can ever outgrow celiac disease?
We see a lot of patients who thought they outgrew it during their college years, and then they come back and but no. Potential celiac disease, which is having the autoimmunity, having the antibodies without the biopsy, there is some data for that resolving, but celiac disease with duodenal lesion, with duodenal damage, no.
And this is some part of the reason why the IL-2 test works, is because the gluten reactive T cells that it's measuring, once you have them, you have them. And even if you're on a gluten-free diet for a long time, they're still there. And that's part of the reason why it doesn't go away.
Couple reports out there of people getting bone marrow transplants and being cured, but it takes ablating all your T cells.
Perfect. And then slightly related, can you speak a little bit to the use of serologies for diagnosis and monitoring? I think we got a lot of questions about differentiating that and where we stand currently, and perhaps how this new research might be involved in that. So we touched a little bit on that as well.
So serology is really approved as a diagnostic test. We use it in follow-up because it is at some level a marker of gluten-driven immune activation, but it's not a very precise marker. And so often it's useful just to see that it's going down and we're seeing a response. When it's persistently mildly elevated, I think that's more complicated, and it's really an evaluation of the patient and not just a lab work to decide what to do. And once it has gone to normal, often you need to introduce a lot of gluten in order to get it back up again.
Absolutely, and the other side of this is that when you have a patient with persistent symptoms and you're worried about refractory disease, having a negative serology is not a guarantee at all of not having refractory celiac disease. So it's not a great test for that. Lately, with people getting more of the DGPs and the TTG IgGs, I have a lot of patients very nervous by persistently elevated blood tests, and I think this has gotten me to do more healing biopsies at 2 years that are normal despite mildly elevated serologies.
And if you would both wouldn't mind sharing how frequently you're checking serologies in your patients, or what your general recommendation is.
I tend to check at diagnosis, and then I don't usually check until 6 months, because if it almost doesn't matter what the result is. If the patient is responding clinically as I expect, I'm not going to change what I do. And then at 6 months, I hope to see that it's gone down. In patients where it's been very high, above the upper limit of quantification for the assay, often it's still there. That doesn't mean they're not responding. It's just meant they went from a whole lot to lots and lots, and it's still above that threshold. And then once they've seroreverted and it's within the reference range for the assay, I check every year or two, or if there's a concern.
Yeah, I do the same, and it's actually, I think, a common reason for referral, that persistently elevated above the quantifiable range, right? Above 10 times the upper limit of normal on the Quest assay, very commonly get referred as refractory, but they actually are doing quite well. They feel well. You biopsy them, they're normal, even with persistently elevated serologies. And I think monitoring with serologies is one of those things that, with time, we may end up uh, adding to the choosing wisely in celiac disease to start to avoid doing.
Thank you. Where should people look for information if they're interested in participating in any of these studies that seem to be coming to the US?
Good question. And I was trying to answer that question
Yeah.
in the chat. So right now we are currently recruiting children with a confirmed diagnosis of celiac disease for a single dose gluten challenge study in conjunction with the whole blood assay. And the reason why we're doing that is it's really important to see that the test works in people that you know have celiac disease before you use it to diagnose people that you're not sure if they have celiac disease or not. And so part of the diagnostic development process is to check those ones that really, really should be positive, and then check people who you're not sure in conjunction with a biopsy. And then you can start thinking about doing it in other people. And it's a matter of scale, because you have to remember that literally hundreds of children are diagnosed with celiac disease in the United States every week. And so if it's 97% good, that could still be 100 children who are getting misdiagnosed every week. And so we really need more data to understand how the test works, especially in patients who maybe have potential celiac disease and don't have the biopsy changes, before we know how to use it clinically. And we're hoping to soon be recruiting in Boston as well. And you can find information if you go to trials.gov.
Perfect. Thank you. So yeah, I mean, I think along those lines, we've gotten a lot of different questions about clinical uses that I imagine maybe down the line, in terms of like using this testing to know if a gluten exposure has happened, for example, or if they could be used more in the clinical setting rather than research.
Yeah, and I think one of the things about the test is that the baseline is really important if you're doing the single dose gluten challenge. And baseline fluctuates. So your baseline from yesterday isn't your baseline from before you ate something that might have had gluten. There is some, if you do have a gluten exposure, then it expands your gluten reactive T cells. So you have more T cells to react, and we would see more of a response. And so serial testing could potentially be helpful in that respect. But we don't know, which is why we need to do more studies.
Thank you. In thinking about who to screen and diagnosis, are there any general trends for pediatric diagnoses versus older individuals in terms of symptoms or nutritional deficiencies they may present with? And if so, how can this be communicated more to general primary care providers or the community to increase screening to capture more patients?
And I think that's really in pediatrics where the discussion is right now. And it's sort of another topic for another seminar, but certainly there are countries in Europe where they are screening all children for celiac disease. And part of the reason for that is there's no really good list of symptoms that's going to find more people with celiac disease than taking random people and screening them for celiac disease. And so we definitely know that first-degree relatives are at increased risk. Patients with type 1 diabetes are at increased risk. Patients with Down syndrome are at increased risk. And so those groups certainly should be screened, but even within the general population, it's hard to pinpoint. So I always say if there's anything that could potentially be related to celiac disease, you're not wrong to screen.
In adults, I think we miss the mark very, very often. Just iron deficiency anemia, as you saw with the case, should be like one, unless you have a straightforward answer, right? Because sometimes you do, but you should investigate iron deficiency anemia, have a TTG and an IgA, and the same with any diagnosis of IBS diarrhea. That's we see a lot of diagnosis of IBS, and then they get referred for refractory IBS, and no one had checked the TTG ever. So we still miss many of these, and I think that's a very good population to check.
Perfect. Thank you. And I imagine we have also gotten questions specifically about infertility and how it may contribute to that, but that may also be a good opportunity to screen for it as well, or history of that.
And also being mindful that if you screened somebody 10 years ago and they didn't have celiac disease then, they could have developed it in the last 10 years. And so having one negative test, especially if it was many years ago, really doesn't rule out celiac disease.
Yeah, absolutely. With infertility, I do feel like infertility docs are, very, very prone to testing. I get quite a few referrals from Boston IVF. So I think they're doing their job, but I feel like it's in general GI clinic or in the primary care clinic where we're really not doing it.
Okay. And then I think as we're getting close to the end, there have been a lot of questions about when this might be more widely available, the newer diagnostic techniques. And I know there's a lot of steps to go before with clinical trials, but any sense of looking into a crystal ball, how long it might be before people could see this?
I think it might be that it's available at different levels at different times. And right now, we don't have sufficient evidence to be able to guide us to use it and recommend it in clinical practice. It seems really good, and hopefully it really is really good, but we have to test it in some of those harder scenarios to really understand. There's also some technical things about the test which make it more challenging than a lot of the routine blood tests that we do.
Perfect. Thank you. I guess one last question that we've also gotten a few times is more about screening and screening in asymptomatic individuals, particularly family members, when to screen and then how frequently to screen those individuals.
So I usually see the kids, so I'll start there. So if I diagnose a child, then I recommend that all first-degree relatives get screened. So that's parents and siblings. And then if there's any other family members who are like, oh, I think I have this too, definitely screen them. I think probably if you haven't had exposure to gluten yet, it's too young to screen. But certainly celiac disease can develop very soon after that first gluten exposure. And from some of these prospective studies, we know that a lot of celiac disease develops between age 2, 3, 4, 5. And so I think it's important to screen early on in age 2, and then also think of screening again before starting school. And then after that, you can probably space it a little more. But of course, if the child develops something that could be celiac disease, they should be screened. For the family, for the older adults, I think my personal bias is that likely they're less likely to develop celiac disease than the 3 or 5-year-old. And so again, I wouldn't test them routinely unless they have a symptom.
Yeah. Many of them, it's interesting how the adult relatives of kids that are diagnosed, usually everyone gets tested. And not the other way around. Like when an adult gets diagnosed, like he or she will tell the siblings, and siblings are, I don't want to get tested for this. I don't want to know. But kids really bring people together, whereas I feel like that adults not as much. But yeah, I usually test at least once, and then tell them like if they develop symptoms.
Thank you both so much, and thank you for the presentations today. I think we're at the end of our time, so I'll turn it back to Chris Rich.
Well, thank you, Dr. Olshan, and thank you to all of our presenters and attendees for your participation today. We hope that all in attendance found this webinar educational and helpful. Please note that if you have registered for the continuing education units by following the instructions that were presented to you in the chat box, those units should be received in the next 2 to 3 business days. Also, please remember that the recording of this and all past webinars in the All Things Celiac webinar series can be found at nationalceliac.org. We encourage you to keep an eye on the Harvard Medical School and National Celiac Association websites and social media accounts for updates and additional information about the timing of future All Things Celiac webinars. So on behalf of all of our esteemed guests and from all of us here, we look forward to seeing you next time, and thank you for your continued support.